Well, hello. It's Dr. Matt. Your first year emergency and critical care resident at North Carolina State University, College of Veterinary Medicine, Veterinary Teaching Hospital. And as always, they don't specifically endorse my channel. High output heart failure is something that I recently learned about. Definitely did not learn in vet school. Spoke with the cardiology department, and a lot of them said they learned it after vet school. So I had two cases. So I find this really interesting and something that's really important for other people to know. So this is the outline. So what is cardiac output? So remember that cardiac output is equal to heart rate times stroke volume. And that heart rate, so essentially there's multiple factors for that. So autonomic innervation, whether that be parasympathetic or sympathetic, certain hormones, fitness level, and age. Remember that stroke volume is equal to the end diastolic volume minus the end systolic volume, and factors that contribute to stroke volume include heart size, fitness level, gender, more so in people, contractility, preload, and afterload. And remember that you can rearrange the blood pressure equation, which is typically BP equals cardiac output times systemic vascular resistance, but you can rearrange that to get cardiac output over, oh gosh, you can rearrange that equation to get cardiac output equals blood pressure over systemic vascular resistance. So what is it? And how's it different than congestive traditional heart failure? So in congestive heart failure, there's either a reduction in systolic and or the diastolic function with an increased systemic vascular resistance leading to hypothermia, cool periphery, and extremities. In contrast, high output heart failure has normal function, but a decreased systemic vascular resistance, leading to normothermia, maybe even hyperthermia, warm extremities, and periphery. And this is a kind of a illustrative depiction, which might help you understand the different causes. And we'll talk about the causes that you see on this page in just a moment. So in terms of causes, so there's two major categories, which include the increased metabolic states, as well as increased perfusion into the venous circulation. And then there's subcategories of that include metabolic, myocardial, mechanical vascular, and a combination of those. In terms of increased metabolic states, we'll talk about it more on the next page, but it would include hyperthyroidism, myeloproliferative disorders, and Paget's disease. For increased perfusion into the venous circulation, certain causes would be a arteriovenous fistula, hepatic cirrhosis, and obesity. For myocardial, you can have hyperthyroidism, sepsis, severe thiamine deficiency, chronic pulmonary disease, mitochondrial diseases, and acromegaly. And then additionally, what's not listed on here would be like physiologic causes, including pregnancy, fever, and infection, and then iatrogenic causes with administration of medications that induce pulmonary vasodilation, similar to sildenafil, and then ionotropes, similar to pemobendin. So what we'll talk about first is in people because it's more well described with the landmark paper called High Output Heart Failure, a 15-year experience coming out of the Mayo Clinic. So they found that obesity is about a third of the cause in people. And essentially the reason for that is in people with a BMI of greater than 30, the mechanism's not specifically elucidated, but they do suspect it's due to vasoactive adipokines and a direct effect on cardiac function by the changing myocardial metabolism and remodeling, secondary to insulin resistance and increased fatty acid oxidation, leading to left ventricular dysfunction. And depending on the report that you read, there can be up to a 50% reduction in the left ventricular efficiency. And then other theories have also pointed that there might be increased renal hypoperfusion leading to sodium and water retention and therefore increased cardiac work. So other diseases such as hepatic disease, so that can either be alcoholic or non-alcoholic cirrhosis, portal hypertension, anything similar to that. Arteriovenous shunts, pulmonary disease, Myeloproliferative disorders such as chronic or acute leukemias or lymphomas, chronic and severe anemia, and then acute septic shock. So on the veterinary side of things, so small animals. So most common causes include hyperthyroidism, which generally leads to an increased contractility and it's a positive chronotrope, leading to increased cellular waste products and therefore causing a secondary reduction in systemic vascular resistance to try and improve the clearance of those byproducts, but eventually leads to volume overload. And then chronic and severe anemia secondary to just a decreased oxygen carrying capacity, leading to increased waste buildup, kind of similar to hyperthyroidism. Sepsis, so there's widespread or global inflammatory response like SIRS, leading to global vasodilation. And what's important to know about that is that initially these patients are hypovolemic, but after volume resuscitation, they are kind of in this hyperdynamic phase with a high output but a low systemic vascular resistance, which leads to decreased or depressed myocardial function. And then what I forgot to mention about hepatic disease or like cirrhosis, essentially kind of what's theorized about that is that there's decreased clearance of vasodilatory substances, which kind of causes this global vasodilation. Other causes that have been theorized in people, but not specifically, are kind of like 100% determined, would include erythroderma, carcinoid syndrome, mitochondrial diseases, acromegaly, and Paget's disease of bone. And then other causes of arteriovenous fistula that I also forgot to mention would include like trauma, iatrogenic from puncture wounds, formation secondary from hemodialysis, transjugular intrahepatic pornosystemic shunting, arterial punctures, and skeletal disorders where there's extensive bone turnover similar to Paget's disease. And again, this is another graphical depiction or illustrative depiction. So in terms of the mortality, so it was determined by the Mayo Clinic study that everyone with high output cardiac failure, regardless of the cause, was likely to have a higher rate of mortality, especially compared to controls. So what they found that there was eccentric left ventricular remodeling, greater natriuretic peptide activation, higher filling pressures, pulmonary hypertension, and increased cardiac output. The elevated cardiac output was related to both lower arterial afterload, so it decreased systemic vascular resistance, and a higher metabolic rate. They found that mortality was increased in these patients up to 38% compared to controls being about 0%, and the hazard ratio being about 3.4. They also mentioned that hemodynamics and outcomes were poorest amongst the patients with the lowest systemic vascular resistance compared to those with mildly or normal depressed, yes, mildly depressed or normal systemic vascular resistance. So thiamine, which is vitamin B1, I think is really important to understand because this can lead to something called beriberi, which is not really well described in animals, but it is in people. And considering that it can cause high output cardiac failure, it's something that's really important to mention and pretty easy and relatively benign to supplement. So thiamine dipyrophosphate, it's a cofactor involved in primarily carbohydrate metabolism, used by enzymes such as transketolase, alpha ketoglutarate dehydrogenase, pyruvate dehydrogenase, and branch chain alpha keto acid dehydrogenase, which are all kind of these links between glycolysis, the citric acid cycle, and the pentose phosphate pathway. And all these produce ATP, NADPH, and ribose 5 phosphate, which the important enzymes that I kind of talked about are here outlined in blue, here, 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 and here. And then a study by Ekram et al. Called the hemodynamic, histopathological, and hormonal features of alcoholic cardiac beriberi. It's a case series, and they said that the affected cardiomyocytes were directly uh, induced to have vacuolization, edema with myofiber hypertrophy, fibrosis, and cellular infiltration, ultimately leading to an increased preload and therefore high cardiac output. Another interesting thing that I stumbled upon um, was relatively new in 2023 in the Journal of Internal and Emergency Medicine. This is for people. It's a case report talking about a 67-year-old woman with end-stage renal disease on maintenance hemodialysis, in which they found an aortocaval fistula on color Doppler. Retrospectively, they were able to determine that there was a documented continuous murmur kind of in the correct region, and that cardiac focused ultrasound showed dilated right chambers, moderate tricuspid regurgitation, and moderate to severe aortic regurgitation, which was confirmed with CT. And aortic cavofistulae are pretty rare in people, with about 80% of them being due to a ruptured aortic aneurysm, and the remainder being congenital or traumatic. So as you can kind of see in this image here, this is kind of what they're talking about with the connection between the aorta and the inferior vena cava. So, clinical signs or symptoms. So it depends on if it's the left or the right heart. But what you can see with both is tachycardia, a heart murmur, plus or minus a gallop rhythm. And so in right failure, you're more likely to see abdominal, pericardial, and or pleural effusion, peripheral edema, hepatomegaly, jugular venous distension, and they can be positive for hepatojugular reflux. In terms of left-sided failure, you're more likely to see like pulmonary edema, dyspnea, and syncope, but with biventricular failure, you can see a mixture of both of these. So the pathophysiology kind of has like three pillars. So like what we talked about is decreased systemic vascular resistance, which is different than it being increased in traditional congestive heart failure, a decreased arterial venous oxygen gradient, and then elevated cardiac output that's still not sufficient to meet the demand. So think of it as a relatively normal heart that can't keep up with the work compared to congestive heart failure where it's a diseased heart that can't keep up with the work. So as you can kind of see in this image with the RAS system, so it's neurohormonal alterations that you can see similarly in traditional congestive heart failure. And what this does is it serves to increase the intravascular blood volume in acute settings, but it does lead to a progressive decline in cardiac function in kind of chronic settings, with remodeling primarily being such as like a hypertrophic phenotype to maintain contractility and reduce the mural stress secondary from dilatation. But with excessive dilatation, you will eventually go into heart failure. So the goals of the RAS system are decreased renal arterial perfusion that leads to increased secretion of renin by the JGA, which eventually leads to an increase in angiotensin 2 and therefore aldosterone, and therefore the thirst receptors or the osmoreceptors in the hypothalamus. And what aldosterone does is it increases sodium reabsorption, leading to water retention and therefore increased preload. But in poor cardiac function, it does lead to hypervolemia or fluid overload. With the adrenergic system, so this is primarily when you think about the sympathetic nervous system. So what it is it's an increased cardiac output or positive ionotropy. Sorry about that. Ionotropy by increasing contractility and heart rate while maintaining systemic BP via vasoconstriction. And this is secondary primarily to epinephrine and norepinephrine. Additionally, the activation of the baroreceptors in the carotid sinus and the aortic arch lead to a decreased transmission in response to the low blood pressure and therefore an increase in systemic sympathetic stimulation. And eventually, this does lead to ventricular hypertrophy and cardiac remodeling when it's sustained. And then antidiuretic hormone or vasopressin. So the goals of that are to induce water retention at the level of the kidneys and vasoconstriction. So what does it do? Well, it binds the type 2 receptor in the principal cells of the late distal convoluted tubule in the collecting duct, and that triggers cyclic AMP, leading to phosphorylation of the aquaporin 2 receptors and channels by protein kinase A. And these aquaporin 2 channels insert into the apical membrane and allow for water to passively move into the cell with guidance by the osmotic gradient set forth by sodium chloride and urea in the medullary interstitium. And it also binds to the vasopressin receptors on vascular smooth muscle and activates G proteins, activating phospholipase C, therefore an acetyl triphosphate and diacylglycerol, and eventually leading to vasoconstriction. And then diacylglycerol and calcium activate protein kinase C, which leads to contraction of the vascular smooth muscle, kind of similar to what I just spoke of. Okay, so the fun stuff. So in terms of workup, so your basic kind of holy trinity, so CBC chemistry plus or minus a urinalysis, and then depending on what you find you suspect, hepatic function test. So you can do ammonia, you can do a pre and a postprandial bile acids, which you should wait until after your chemistry comes back because it will be redundant if you have concurrent hyperbilirubinemia. You can do thiamine testing, which is kind of a pain in the butt because only certain labs run it, and it has to be done via either high pressure liquid chromatography or an erythrocyte transketolase activity assay, which it's just easier to treat empirically for it. And then if you believe they have an infectious disease, you can do troponin or your natriuretic peptides, and then a bone marrow aspirate. And the reason why I say that is if they're chronically anemic, you want to try and figure out why. And then imaging also depends on kind of what you see in your case. So on this slide, you can see this is one of my patients that we'll talk about later that has bilateral pleural effusion, and it's a cat, as you can tell by kind of the vertebral bodies are kind of long and rectangular, more so than in the dog. And with pleural effusion, we think about right heart failure, and you can see this diffuse mixed bronchointerstitial lung pattern in this particular patient. It's kind of hard to see, but there's a little bit of pulmonary arterial dilation, and then clearly you can see this nasogastric tube. Okay, so in terms of an echocardiography, so the left side of the image is echocardiographic images from a dog in the right parasternal long axis view, which shows you moderate left atrial and left ventricular dilation. It's kind of hard to appreciate the right side, but that as well. And then in the next image, or I guess on the right side here, it's the right parasternal long axis view, again with agitated saline injection, which does not show an intracardiac shunt. And then this comes from a study. It's called the Diagnosis of Acute Heart Failure and Computed Tomography Pulmonary Angiography, Feasibility and Accuracy. And essentially what they concluded is that in patients undergoing computed tomography pulmonary angiography, which is CTPA, in whom CT shows no pulmonary embolism, the difference in ratio of the right ventricle and the left ventricle attenuation represents a fast and simple approach to suggest acute heart failure as a differential diagnosis with very good diagnostic performance. And the excellent sensitivity of the two parameters when using optimal thresholds may allow for early diagnosis of acute heart failure and prompt initiation of therapy. So as you can see over here is this kind of the attenuation that they were talking about. Okay, so you kind of treat high output heart failure similar to congestive heart failure in that they need oxygen. You probably should give them loop diuretics such as furosemide. Can you give them PEMO? You could, but if you think about it, it's that the heart is relatively normal in itself, so you could. However, cats kind of do variably with this, and not everything we do is benign. Um, Body cavity paracenteses as normal, and then vasopressor support, since remember that these guys can have decreased systemic vascular resistance, which is kind of one of the hallmarks of this. And then most important, you do need to treat the underlying cause. So one of my patients was pretty severely chronically anemic. So what you're going to do is replace what is lost. So since her circulating volume was fine, we just did packed red blood cells. Since we talked about thiamine and beriberi, you can do thiamine supplementation, which we'll talk about in a bit. And then all these other things, depending on what you think, if it's a myeloproliferative disorder, you can do chemotherapy plus or minus radiation. If it's hyperthyroidism, you can do medical management with methimazole or I-131 or surgical with a thyroidectomy. Or if you think it's a surgical intervention case, like a hepatic arteriovenous malformation. So something that I did want to mention is there was a paper, which is referenced later, and that even these guys that have HOCF and they're anemic, even though they're technically in failure, you need to give them the packed red blood cells. The heart failure does not preclude you from doing it. In fact, fixing the anemia is what's going to fix the HOCF. So what you can do with packed red blood cells is give them over 6 to 10, 12 hours, just to reduce the likelihood of further volume overload. And as you can see here, the difference is, remember, replace what is lost. So if they're just anemic, you just give them packed reds. If they're volume deplete, you can give them whole blood. It just kind of depends. Okay, so thiamine supplementation, after doing a pretty darn deep dive into this, there's no proven clinically backed dosages in either the dog or the cat. But what I found, which kind of kept coming up, was for cats, you usually do about 50 to 100 milligrams per cat, not milligram per kilogram. And you can do it sub-Q, IM, or very slowly IV every 12 to 24 hours for 3 to 5 days, and then follow that with oral therapy for 2 to 4 weeks. What's interesting is that the injectable version, which you see over to the left, actually is pretty rapidly and well absorbed from the GI tract. So you can use the injectable version orally or through the feeding tube. And it's metabolized by the liver and distributed to all tissues, with the highest concentrations being in the liver, brain, kidney, and heart, and then renally excreted. Remember, because it is a B vitamin and it's water soluble, inducing toxicity or overdose is going to be pretty hard. Like, you have to work pretty hard for that. Something that I do need to share is that the pH of thiamine is like 2.5 to 4.5. So it stings. So giving these guys these injections sub-Q or IM sucks. Like, they hate it, especially a cat that's already kind of angry. Some say you can dilute with sterile saline to reduce the pain, but I think what's something that's notable we should bring up is that they've shown that when you dilute Serenia and give it sub-Q with fluids, it changes the pKa, and therefore it changes the uptake and the distribution, which does have clinically significant impacts, or at least so we think it does. And with IV injection, I know people that have done it, but there's been risks of anaphylaxis, neuromuscular, vagal, and ganglionic blockade with apnea and hypotension. And it's no, if they need thiamine that bad, no, they don't need thiamine that bad to give it IV, in my opinion, but doesn't mean I'm right. Some fun facts are that wet foods seem to be especially susceptible to thiamine deficiency, according to a pet food recall that was done several years ago, I think in 2017. From 2010 to 2017, there were 17 recalls of commercially canned cat food, 1 raw cat food, and 5 dry cat foods in the US. The UK recalled 3 dry cat foods, and then Australia had to recall 8 canned cat foods for thiamine deficiency. And then these are some pretty interesting papers. So up here in the top left, the effects of JAK1/2 inhibition of high output heart failure associated with myeloproliferative disease. It's just a single case report, and that pro BNP plasma levels were measured, and they used a drug called, I'm going to spell it, OPZELURA. They didn't observe complete normalization of the pro-BNP, but there was noted to be an increase in systemic vascular resistance. So take that for what you will. The middle paper, called High Output Cardiac Failure in a Dog Secondary to Hepatic Vascular Malformation. So this dog was treated with 4.4 milligrams per kilogram per day of furosemide and eventually did well 9 months later with resolution of cardiac-related symptoms. Surgery was out of the question for these owners, which is totally fine, but the dog was doing really well that far out. And then the bottom right, so treatment of high output cardiac failure secondary to anemia in 3 cats. So this is the paper that I did mention, in that with these heart failure and the volume overloads is that you get worried about giving fluids, IV, no matter what kind of fluids, but you really should not withhold blood from these guys. They need it, right? So there was only 3 cats in this report, but one was a bleeding mass, which was the intestines, one was trauma, and then one was immune-mediated hemolytic anemia. And their conclusion was do not avoid or delay the administration of blood products for these anemic cats in HOCF. Okay, so prognosis. Yeah, it's pretty. Yeah, so the prognosis is pretty up in the air. It depends on the cause. Um, Clearly, with the ones that are anemic and you can find the underlying cause and treat them and they do well, great. For hepatic arteriovenous malformations or fistula, not all of them are surgically good candidates, so on and so forth. So just kind of keep that in mind. What I always tell owners is it really depends on their response to therapy and the degree of their response, and if it's something that we can treat, prevent, or at least significantly reduce. Okay, so some case examples. So these are the 2 cases that I was talking about. I actually got them on the same day as transfers while I was on medicine. So the first case, so this is a geriatric castrated male Maine Coon cat that's indoor and outdoor. He lives in a house with 5 other cats. He's the only one that goes outside. And he was referred for suspected cytozoan felis because he had a pretty severe hemolytic anemia and a secondary suspected consumptive thrombocytopenia. And they took chest x-rays and they found cardiomegaly with pretty significant pulmonary edema, which was secondarily cardiogenic, they suspect. On referral, his physical exam, as you can see over here, he had a grade 2 out of 6 left parasternal murmur with fair to good synchronous femoral pulses, but he was pretty dyspneic with marked expiratory effort and muffled heart sounds eventually, which hopefully helped tell you that this cat had pleural effusion. So on POCUS, what you can see is that on the left, it's a right parasternal short axis view, with this whale being the left atrium. The Mercedes-Benz symbol, which it's not a great one in this image, is the aortic valve or the aorta. And so in cats, a normal LA to AO should be less than 1.3. But as you can see here, this guy's was about 2 or so. The widest point of the left atrium greater than 1.65 millimeters is strongly suggestive of heart failure in a dyspneic cat, which I don't have the exact measurement, but it was larger than that. And then over here on the right, what you can see is this is the right parasternal short axis or the mushroom view. Mushroom kind of gets away from us a little bit from that shadowing. And the left ventricular end diastolic diameter in cats normally is 1.1 to 1.75, but his was about like 2.5 or 3. So this was his abdominal bedside ultrasound, and that what you can see here, so this is the diaphragm, this is the liver, and then this is going to be in the chest, and you can see some pleural effusion here. And then what you can see is that the hepatic vasculature is relatively dilated, and doing a subxiphoid view, what you can see here is this is the caudal vena cava, which is pretty large. There's a paper by, I can't remember the first author, but DeFrancesco et al. She's one of our criticalist cardiologist, double board certified people at NC State, who's awesome. And they determined in the paper that 15% of cats with cardiogenic pulmonary edema and 71% of cats with cardiogenic cavitary effusion exhibit hepatic vein distension. The p-value was less than 0.0001. And that the caudal vena cava max diameter in 2D ultrasound for healthy cats range from 2.03 to 3 millimeters. For cardiogenic cavitary effusion, 5.3 to 8.4 millimeters. And then cardiogenic pulmonary edema, just under 4 to 7.4 millimeters. So as you can see, this is his lab work here. And so what he has is you can look over here. So his hematocrit's pretty low. So he has a marked normocytic, normochromic, non-regenerative anemia with a mild, relatively mature neutrophilic leukocytosis, as well as a low plasma protein. And then on this chemistry, you can see there's a lot of things going on, but on his coagulation profile, what you can see is that his PTT is too high to read, and his platelets are pretty low. Fortunately, though, his D-dimers are normal and his PT are normal, with his international normalized ratio being 1.09. So, what does that tell us? Well, based on this cat having anemia and the cytozoan felis causing a hemolytic anemia, that it makes sense that he has a pretty good total bilirubin of 5.3, and his albumin and his globulin, so that could either be a PLE, a hemorrhage, or potentially could be like third spacing, pretty significant third spacing. And his kidney value, so his BUN's a little bit high, but his creatinine's a little low, so his muscle condition score is a little bit low, and that his BUN being high could indicate either a pre and or renal azotemia or GI hemorrhage. So we did a right-sided thoraco or pleurocentesis, and essentially there's no infectious agents but a low protein transudate. And what I forgot to mention is that on his blood smear, the pathologist did find a lot of cytozoan schizons in the macrophages. So these were his chest x-rays. These were shortly after his pleurocentesis. And as you can see, there's still a pretty significant amount of pleural effusion because there's a lot of border effacement of the heart, and after we place an NG tube into him. So this is his problem list. So the pleural effusion, so vasculitis, remember that cytozoan felis really dodoes like the endothelial cells. He was also hypoalbuminemic, and he did have an increased hydrostatic pressure from high output heart failure. So essentially all those things could be contributing. The panhypoproteinemia, I think, was more so due to pretty significant third spacing, but we also couldn't rule out that this cat also had GI disease. And then his normocytic, normochromic, non-regenerative anemia. So since this was pretty acute, we can't really rule out pre-regenerative anemia. We know he was kind of ill for about 3 days, which we start approaching kind of like the regenerative stage. But the anemia of inflammatory or chronic disease is kind of the biggest differential. And so remember that in pretty significant inflammation, there's pro-inflammatory cytokines and hepcidin that block intestinal iron absorption, which leads to iron retention within the reticular endothelial cells. There's suppressed erythropoietin response to anemia, and then secondary inhibition of erythroid cell differentiation. This is the most common type of anemia in hospitalized or chronically ill patients, with it being the second most prevalent in the world after iron deficiency. And some of these pro-inflammatory mediators include interleukin-1 beta, interleukin-6, and lipopolysaccharide or endotoxin, which induce hepcidin to a pretty significant degree. And with interleukin-1 beta, interleukin-6, and interleukin-10 with interferon gamma promoting iron uptake into macrophages, increasing radical-mediated damage to the erythrocytes, and their ingestion by macrophages cause efficient iron storage by stimulating ferritin production and blocking iron transport by ferroportin-1. It's a lot, I know. In terms of EPOs, or interleukin-1 and tumor necrosis factor actually inhibit the formation of EPO, and therefore inhibit the EPO-R receptor and mediated signaling. And that erythroid iron deficiency limits heme and hemoglobin synthesis, also reduces expression of EPO-R receptor, and then blunted signaling expression of scribble, which I cannot remember what that is. So what did we do? So fortunately, one of the most up-to-date, newest, even though it's been a few years, treatments for cytozoan felis has been published. It was done at NC State University by Adam Birkenhauer, one of our internists. And so essentially with these cats, you put them on heparin CRIs, you put them on atovaquone and azithromycin, and you just touch them the least amount as possible and give them transfusions as needed. For him, he was not given a heparin loading dose. He was just put on 600 units per kilo per day, which is kind of where we started NC State. He was put on gabapentin because he was pretty stressed, and then meropenem on Zanzatrone because he's pretty nauseous and didn't want to eat, and then cisapride a few days later because he wasn't really still wanting to eat, but also was showing a couple signs of regurgitation. And then about 3 days in, we put him on an anti-inflammatory dose of dexamethasone sodium phosphate to help with the inflammation secondary to the infection and treating it. We did enterally feed him and supplement him with IV amino acids, and he did also get fortified vitamin B complex. And how we start the dosing is 0.4 mils of B complex per 100 kcals of RER, diluted 1 to 10, given about over 30 minutes IV once a day. He was in an oxygen cage. He got various fluids. He got 3 transfusions of feline packed reds, and then the traditional 10 mg per kg of azithromycin once a day for 10 days, and 15 mg per kg of atovaquone 3 times a day for 10 days. And then I think 4 days in, he still wasn't responding as we typically expect. So we were worried about, potential other co-infection. But this cat needed to keep his blood because he's pretty anemic. So we didn't submit a vector-borne disease panel. We just empirically started him on 7.5 milligrams per kilogram of Veriflox POQ24 until gone. So his overall differentials, Cytosol Felis was up there, but we couldn't rule out like a mycoplasma, Bartonella, Ehrlichia, FELV, or FIV. We did triple test him later on, and he was negative for feline leukemia and FIV, which isn't a hard and fast, but less likely. There's other toxins he could have access to, and like a microangiopathic vascular disease, or a primary IMHA with just happens to have cytozoan. But fortunately, he was discharged after 8 long days in the hospital and a lot of money. And he's doing really well at home. I just spoke to the owners and I'm so glad. And all their other cats are going on flea tick prevention. Okay, case 2. So this is a pretty young, exotic purebred cat with a 1 week history of a fever of over 105, pretty severe chronic anemia. Was positive for tapeworm antigen on fecal, and then reported to have 2 seizures, with the first one being caught on video that I saw was a generalized tonic-clonic, pretty violent, and then a kind of like a focal tonic in the thoracic limbs in the head. Ammonia and pre and post bile acids were normal, with the hyperbilirubinemia progressing. And then she was mildly febrile with decreased muscle mass and dehydrated. What's interesting with her is she had a 2 out of 6 right parasternal murmur and then a pretty loud gallop on the left. So there probably was a murmur on the left, but the gallop was just so loud. And then she had increased lung sounds everywhere with mild expiratory wheezes and a marked expiratory effort. So a lot of red. So essentially in her blood work, she had a marked normocytic to microcytic hypochromic non-regenerative anemia, which fits best with iron deficiency. A marked thrombocytopenia with evidence of regeneration because the MPV is pretty high at 30.1. And then a neutrophilic leukocytosis with a left shift. On the right side with her chemistry, you can see that she has a pretty high BUN, a moderate to marked hypoalbuminemia, low normal globulins, a pretty marked hyperbilirubinemia, and a pretty mild myopathy. With infectious disease PCR and serology panel pending. So this little kitty cat was pretty small, so getting blood from her was not the safest thing to do. So what we did is we submitted a Bartonella serology panel that required like 0.5 ml, a toxoplasma, ELISA to Colorado State University, and then this pretty extensive FUO panel through IDEX through the primary care vet. These are her x-rays. As you can see, she has cardiomegaly. She does have some cardiogenic pulmonary edema. And then here, she's got like the Valentine-shaped heart, but it's primarily right-sided enlargement. So this was her echo. We were able to safely get her in a couple days after transfer to medicine. And the echo revealed she had pretty severe right atrial and right ventricular dilation with moderate left atrial dilation and a high normal left ventricular chamber dimension. She had high normal to hyperdynamic left and right ventricular systolic function with mild tricuspid regurgitation. Basically, what cardio is suspected is she's consistent with the high output state given the systemic illness, the fever, the anemia, and the subsequent left heart failure, but there is no effusion, but the caudal vena cava is pretty large. And then what you can see here was pretty fascinating in that At first, it was suspected that she might have a coronary cameral fistula, which is something I've never heard of before. But kind of retrospectively, we looked back at it, and it could just be pretty severe dilation from the coronary sinus, which we don't typically see, but given her high output state, um, yeah, so something really fascinating, at least to me. Then we had an abdominal ultrasound done bedside. So as you can see, her caudal vena cava is huge compared to her aorta, which makes sense with the right-sided failure. And then she kind of had this hypoechoic hepatomegaly, which could be infectious or inflammatory hepatitis. So as you can see, this is the liver and this is the right kidney because they abut each other. So this is her problem list. So what I forgot to mention is for left-sided failure is this cat was given like 4 mgs per kg per day equivalent of pred for dexamethasone SP for like 2 or 3 days, which is really, really high. And it's unclear as to why that dose was given, or if it was just an error in like putting in the medical records. But we couldn't rule out like a congenital we couldn't find or a primary heart disease. The right side was high output failure, but we also couldn't rule out a chronic pulmonary disease. The hyperbilirubinemia was primarily extravascular because surprisingly, her urine and her plasma were not that icteric. I skipped over the subretinal infiltrates. We had an ophtho consult, and that's what they saw. Seizures, intraverse extracranial. So things could include like infectious for intracranial, like FIP, Bartonella, and toxoplasma. Extracranial could be a thiamine deficiency, electrolyte disturbance, or like a weird aberrant parasite migration. And what I don't like is this cat's having signs consistent with iron deficiency anemia. And considering that infectious was pretty high on my list, I was getting worried about like infectious infiltration into the marrow. So, like a myelophthisis. Sure, could a really severe inflammation cause it? Sure. Um, Loss from the GI tract possible. The owners never reported like a hematochezia or a melanite. She did have a couple days where it was pretty mild, which does make sense because she had a discordant BUN and a creatinine. So what did we do to treat her? Well, we were supporting her with levetiracetam or Keppra for her seizures. We did start her on a hefty dose of thiamine, so she was getting 100 milligrams of the injectable version orally, Q12, which we were kind of able to back down to 50 milligrams by mouth Q12. And then after 2 days of that, stopped it. Her Dex SP was decreased to physiologic, so 0.05 mg per kg. Her furosemide kind of varied, but we were able to taper it off. And then since getting blood from her and waiting for the infectious disease panel on how ill this cat was, we did start her on Doxy, Clinda, and Veriflox, which let me tell you, Doxy and Clinda tableted versions, was freaking out this cat was going to get a stricture. But luckily my staff are amazing and that did not happen. So overall infectious differentials would be like an FIP. All of her testing came back negative for Bartonella, toxoplasma via serology and PCR. And then we couldn't really rule out like a vitamin B deficiency. But so tentatively diagnosed with FIP because everything came back negative. She was there for 9 long days with a lot of care, money, and time. Quickly became a favorite in the hospital and spoke to the owners several times, including this morning, about a week or two later, and she's doing really well at home, and the diarrhea has now subsided. So these are some of my references. And then some images from residency. So the first time I prescribed meropenem, which made me want to throw up. This was my first shift as a supervisor overnight. This was IVEX with Frank. He's an amazing student. He's going to be an amazing ER doctor. Hopefully he wants to do a residency. This is my resident mate, Maria, who I love. And then one night we had this oxygen dependent dog that we couldn't get out of oxygen to do an ABG. So I went in with him. As you can see, there's the oxygen cage with me. This was way after. I thought to take a picture afterwards, which is why the blood looks kind of weird. And then shortly after getting this, the blood gas machine went down for quality control, like literally as we were entering in the sample. Over here, I taught an intern how to do a chest tap, which was super exciting for me. And then I survived 6 consecutive nights, so 90 hours. Uh, and I hibernated for 4 days and 4 nights. And on my last day, I mean, damn, look at those bags, girl. Like, damn. Surprised they're not like Louis Vuitton. These are like dollar store bags. But tried to open up a car that looked very similar to mine that was not mine. So yeah. Thanks for tuning in. Hopefully you learned something. I know this is a lot, but hopefully you found this as interesting as I did. If you liked it, give it a good old like. If you didn't, let me know below. If there's anything that you want to learn that's ECC related coming up soon, just leave a comment. Thanks a lot.